ఆకాశం కిందే పండగే ఫుల్ తయారుందే చుక్కల ఆకాశం కిందే పండగే ఫుల్ తయారుందే ఎగరు పంజరాలే ఇల్లా ఆగమిక ఇచ్చాల్లా నేటికి కదే లేచిని చేయడానికి తల్లా రేయి పగలు ఏదైనా కానీ మనముంటే యాదాది వాలి దునియా సలామే సలామే సలామలాలి దునియా సలామే సలామే సలామలాలి రేసలా హైరే జమాని దునియా డేరా కవాలి సలామే సలామే సలామలాలి ఏమైనా సరే నమ్మద్దు సమాన ఇది నిన్ను మోసమే చేసేదా పైన ఉన్న తారలన్నీ నేల మీద ఒక్కసారి విప్పునటామా ఫైటింగే అంతా మనదే నామంతే అదిరను జోడి ఇది ఆనందే అడ్డొస్తే కాకలు చేయంలే ఆ పనులేనంతే నేడు మహబూబాల భలే కలుగు నడుస్తుందే
మన ల్యాప్టాప్ ఆగింది స్పీక్ మోడ్ తీసే తీసాను యాపిల్ ఉమా ఉమా ఏరా ఇటేనండి ఇటేనండి అవే కెమెరా ఉంది వేస్తుంది
A very good morning to all the dignitaries, respected faculty members, and my dear colleagues. It gives me immense pleasure to welcome you all to the Neuro Update 2025, organized by the Department of General Medicine GEMS. We are truly honored to have with us a distinguished panel of speakers, renowned experts, and pioneers in the field of neurology. Let us all actively participate and make the most out of today's session. On that note, I warmly invite Dr. Gopi Sir, Professor and Head of the Department of Neurology, Andhra Medical College, to lead the first session. I also invite Dr. Madhusudan Babu Sir, Professor of Medicine, GEMS Hospital, and Dr. Usharani Ma'am, Assistant Professor of Medicine, GEMS Hospital, to kindly serve as chairpersons. Sir, good morning, sir. Sorry, madam, CV మీది చదువుతారు సార్ తర్వాత.
రవిశంకర్ ఫోటో తీయండి. ముందుకు వస్తే ఒకసారి పర్లేదు. ఇటు వచ్చాము ఇప్పుడు తీయండి. ఇప్పుడు తీయండి. అక్కడ తీయండి.
Yes. Good morning, sir. It is indeed an honor to introduce Dr. Gopi, sir, a distinguished neurologist and academician who currently serves as professor and head of the Department of Neurology at Andhra Medical College, Visakhapatnam, with an educational background of MBBS, MD in General Medicine, and DM in Neurology. Dr. Gopi, sir, has built a career marked by dedication to patient care, teaching, and research. His key areas of interest include headache, stroke, epilepsy, and movement disorders, fields in which he has made significant clinical and academic contributions. SAR has been actively involved in advancing neurological sciences through research and publications with more than 30 articles published in indexed journals. He has presented his work at several prestigious national and international conferences, including the World Congress of Neurology at Bangkok, and has delivered numerous guest lectures that have enriched academic forums across the country. His role as an external examiner, thesis evaluator, and paper setter for multiple universities, along with his service as an NMC and DNB inspector, reflects his influence in shaping neurology training and education across India. Apart from his academic and clinical excellence, Dr. Gopi sir has been actively involved in organizing and leading academic events. He has conducted several CME programs and conferences, and he is currently serving as the organizing secretary of IANCon 2024, a national level conference of immense importance to the neurology fraternity. His leadership in such platforms has fostered collaborative learning and advancement of neurological sciences. Dr. Dr. Gopi sir achievements have been recognized through multiple awards and honors. He is the proud recipient of the Times of India AP Health Icon Award 2023 and the Certificate of Merit Award awarded by the District Collector of Visakhapatnam on the occasion of the 76th Republic Day in 2025. His academic journey has also been decorated with several gold medals and national level prizes during his formative years and reflecting his consistent pursuit of excellence from the very beginning.
With all this introduction, of course, many are left over. I invite Professor Gopi to enlighten us on approach to acute encephalitic syndromes. Over to Dr. Gopi.
Good morning to all of you. First of all, I'm very happy here for two reasons. One is one of our brilliant student, Dr. Priya, is conducting this conference. One other thing is I'm very, very happy. One of my most favorite, very brilliant teacher, Dr. Masoor Babu, my teacher, is chairing my session. Thank you very much, sir. I'm honored. And thank you, Dr. Usha, for and one of my student, Dr. Ravi Shankar, also is here. So, good morning to all of you. What I'm going to cover in the coming 40 minutes is about how to approach encephalitis case. This is very important because encephalitis has diverse etiology and a low diagnostic test and very low yield of the microbiological isolation. And you see, encephalitis means it can be viral, bacterial, fungal, parasitic, not only infectious, metabolic, drug-induced, toxin-induced, septic encephalopathies, and mitochondrial disorders. And very important is autoimmune encephalitis, where you don't get fever, but looks like encephalitis. So how to approach? I'll give you a bird's eye view. So inflammation in the brain, anywhere encephalitis means inflammation. Inflammation in the brain is encephalitis. First you should differentiate encephalopathy from encephalitis. Encephalopathy means altered consciousness. You're all alert. You're very, very much alert. You're so and so. You're sitting in James Auditorium, 4th floor. Today is 31st August 2025. Today is Ashtami, another Nakshatram. So you know with all Panchang, you're very much aware of yourself and surroundings. Somebody is drowsy, confusion, obtundation, stuporous, comatose. So this is change in alertness. Any patient who presents with change in alertness, that is encephalopathy. They need not have fever. Encephalopathy plus these two things, like any of the either fever, any two. One is patient's altered sensorium. Apart from altered sensorium, patient has fever or seizures or either CSF, imaging or EEG findings. Either one, two clinical findings like seizure and fever. So any patient who is altered sensorium with a fever, seizures, with CSF or EEG or imaging finding abnormality, any two of these, that is encephalitis. So you have WHO recommended case definition of encephalitis, acute onset of fever, change in mental status, and or new onset of seizures. So you have International Encephalitis Consortium for encephalitis criteria. Major is neurological dysfunction manifesting as altered mental status, perfect alertness to either drowsy or lethargy or confusion or obtundation or comatose. Good morning, sir. So minor criteria apart from the altered mental status, either fever or new onset of focal deficit or CSF abnormality or EEG abnormality and imaging abnormality. So different to, you have different to probable, possible. Different to means either microbiological evidence or pathological evidence or evidence of autoimmune encephalitis. That is different to encephalitis. Probable means major criteria plus one minor criteria. Possible means one major and two minor. So if you say epidemiology of encephalitis, most common cause of acute encephalitis. Any patient who comes with fever, altered sensorium, most common is viral encephalitis. So at the end of 40 minutes, you should know the encephalitis important is viral. In the virus, it is Japanese herpes simplex encephalitis. Apart from these two, we have dengue encephalitis and strep typhus nowadays, especially in the last 10 years. So these four are very important. Japanese encephalitis, herpes simplex encephalitis, dengue encephalitis, strep typhus encephalitis. Apart from these, we have various autoimmune encephalitis. Most common cause is viral encephalitis. Most common cause of viral encephalitis in India is Japanese encephalitis. Most common cause of sporadic encephalitis worldwide is herpes simplex encephalitis. And recurrent disorders like strep typhus, nowadays they're emerging and re-emerging. If you see before 1975, very few cases of Japanese encephalitis before 1975. 1975 to 1999, most of them are encephalitis means Japanese encephalitis alone. After 99, you got a lot of other encephalitis like dengue, strep typhus, chikungunya, influenza, all these can produce encephalitis. If you see this slide, last 2 decades, you can see the increased evidence of strep typhus. In every week, almost we say patient of Shera and fever, systemic features, altered sensorium, and the diagnosis is different. JE diagnosis, treatment is different. So the cases of strep typhus and chikungunya and other viruses, or dengue virus especially, they're increasingly known for the last few decades. Whereas in the very first few years, it is Japanese encephalitis, then herpes simplex encephalitis. There are changing landscapes. So 1998, the hallmark for this Nipah virus. So after that, strep typhus, then you have lychee encephalitis. The lychee encephalitis causes dangerous drop in blood sugar level and leading to encephalitis. That is due to methylene cyclopropyl glycine. That is the important thing which causes drop in blood sugar. The change in landscapes, if you see all encephalitis, 40% infectious encephalitis, remaining 60% non-infectious encephalitis. Especially in the last decade, lot of awareness about autoimmune encephalitis. If you see non-infectious encephalitis, most important is autoimmune encephalitis, then ADM, especially in children, paraneoplastic, and most of them are idiopathic. So encephalitis, the pattern of inflammation can be diffuse, focal, multifocal. It can affect meninges, spinal cord, like meningoencephalitis and encephalomyelitis. So if you see how will you approach encephalitis? So acute encephalitis. Acute encephalitis can be viral, bacterial, fungal, parasitic. Acute means hours to days. Any patient with fever, altered sensorium, within few days to hours, few hours to days. That is acute encephalitis. Classic is viral, bacterial, fungal, parasitic. Subacute means few days to weeks. That is usually again fungal autoimmune encephalitis, very typical of subacute encephalitis. and Mycobacterium tuberculosis is very typical, and chronic HIV, SSP, PMLE, and progressive rubella encephalitis. So the spectrum of encephalitis is infectious, non-infectious, and other causes. Non-infectious, very important, is autoimmune and paraneoplastic. Other causes, metabolic, toxic, septic, mitochondrial. So a lot of agents are there for infectious encephalitis. Most important, I told you, Japanese, herpes, strep dengue, and others. So you have bacterial, fungal, parasitic. Nowadays you have acanthamoeba, Naegleria, hortiminally. So non-infectious inflammation of the brain. So non-infectious causes are acute disseminal encephalomyelitis, autoimmune encephalitis, fires in children, febrile infection-related epilepsy syndromes, paraneoplastic, so uremic encephalopathy, hepatic encephalopathy, diabetic ketoacidosis, hyperosmolarcoma, septic encephalopathy, mitochondrial, drug-induced, all these. So risk factors, who develop encephalitis? Both extremes of age, both old age and children below 10 years, post-transplant individuals, patient who has rheumatological disorders, primary acquired immunodeficiency states, vaccination, and you have to ask about travel, season, and all those things. So what will you do immediately if a patient of altered sensorium? These things you have to follow, 5 steps. The step 1 is rapid assessment and initial stabilization, then detailed history, then investigations, then empirical treatment, then supportive care. So rapid assessment, assessing ABC, airway, breathing, circulation. So the patient's airway is protected, if the breathing is adequate, I need mechanical ventilation is required, especially when the GCS is less than 12. You have to intubate the patient. Or GCS is 14, drop of GCS by 2, you have to incubate. When the bulbar palsy is there, you have to incubate. So you have to see these conditions. Hemodynamic stability must be ensured, and preferably patient be admitted in ICU. So watch for acute reduction in alteration of consciousness, raised ICP, mass effect, or systemic issues like hypoglycemia, fever, electrolyte disturbance, seizures, all you have to see. So immediately you have to treat. That is, cerebral edema is there, mannitol 0.25 to 1 gram per kg bolus every 4 to 6 hours, hypertonic saline, and seizures, first line, lorazepam, midazolam, diazepam, then second line, fosphenytoin, levetiracetam, sodium alipurate, and third line, propofol, phenobarbital, and pentobarbital. So after this, after stabilizing the patient, then you take the detailed history. What is the onset? What is the duration? What is the progression? Is it acute, subacute, chronic? So whether patient had only brain features or systemic features. Somebody has encephalitis, so only central nervous system is affected. Most of the time it is either Japanese or herpes simplex encephalitis or varicella zoster encephalitis. Only CNS features. Somebody has CNS features with systemic features. Then this scrub typhus comes. Nowadays, we see scrub typhus very frequently. And one of our neurosurgery PG's wife expired of scrub typhus just few weeks back. She has fever, altered sensorium, and systemic features like skin rash, myalgia, thrombocytopenia, shock, either hepatic or renal involvement. Like the important causes are cerebral malaria, scrub typhus, dengue, and chikungunya and leptospirosis. So then detail other histories for the demographic, any outbreaks, travel like Nipah virus, where in 1998 in Kerala, Kozhikode. Then recent vaccination, like during COVID, we get a lot of patients of acute disseminated encephalomyelitis. So patient took COVID vaccine. After that, patient developed altered sensorium. So you ask Christopher, recent vaccination, contact with animals like rabies. Rabies can cause rabies encephalitis, and brucellosis, contact with animals, and contact with unchlorinated fresh water, very important cause for primary amoebic meningoencephalitis. You have to ask all these history, and leptospirosis for contact the animal urine, and mosquito bite for arboviral disease, Lyme disease, tick-borne disease, and risk for HIV and immunocompromised states. So then other important history is level of consciousness, whether patient is alert, drowsy, stuporous, comatose, or uptended, signs of impending brain herniation, signs of meningitis, neck stiffness, Kennick's, Budzinski's, Edelman's great toes, and Bickley's sign, subtle motor signs, the twitching of the mouth, twitching of the eyelids, twitching of the digits, papilledema, movement disorders, diffuse rash, enterovirus, vesicular dermatomal rash, varicella zoster. You have to see for the rash, and retinitis for CME. This important rash, maculopapular rash. Nowadays we get a lot of cases of dengue virus. They can fever, rash, myalgias, joint pains, and varicella zoster virus. You get raindrop eruptions all over the body, and mumps look for any perioditis, and CME retinitis, CME encephalitis, and very important stuff types. You have to see for central necrotic scab with perilesional hyperemia. That very important. Ishar is there. Ishar, fever, altered sensorium, and systemic features. very classic of scrub typhus with lymphadenopathy. So detail is, sorry. So acute encephalitis primarily affecting central nervous system, should undergo MRI and start empirical acyclovir. So when you see a patient fever, altered sensorium, primarily involving central nervous system without systemic signs, start acyclovir and go then send for MRI. Acute encephalitis syndrome with systemic features, then test for malaria, scrub typhus, leptospira, and typically start with either doxycycline or erythromycin according to guidelines. So investigation approach in acute encephalitis, in all patients, complete blood count, blood cultures, electrolytes, glucose, liver profile, kidney profile, renal profile, peripheral smear for malaria parasite, and chest X-ray in all patients. In most of the patients, they need neuroimaging, CSF analysis, and some cases you have to go for when you suspect autoimmune encephalitis, like NMDA receptor encephalitis, or you have to go for NMO, MOG, all these things. So you have a CSF PCR panel, what is known as BioFire. BioFire is a short notes for most of the MD general medicine students. It includes total 14 things. The bacterial, viral, yeast. With the 1-2 ml of blood, you can get all these tests. There's Escherichia coli, Haemophilus influenza, Listeria, Neisseria, Streptococcus, CME, Enterovirus, herpes simplex 1-2, and varicella zoster and cryptococcal meningitis. So once you get the CSF analysis, you can easily distinguish what type of encephalitis. Is it viral, bacterial, fungal, parasitic, or tuberculosis? I think I need not discuss. Normal CSF cell count is 0 to 5. Protein is 15 to 45. The protein is increased, cell count is increased, glucose is very much decreased. That suggests of a bacterial meningitis. Tuberculosis meningitis, classically cell count is increased, protein decreased, glucose decreased, not to an extent of bacterial meningitis. With this, you can distinguish grossly viral, bacterial, fungal, parasitic. So acute encephalitis syndrome neuroimaging should be done in all. MRI is preferred than CT. Excludes encephalitic mimics, the presence and extent of inflammation of the brain, radiological signs of increased intracranial pressure, and etiological clues based on the pattern recognition. Once you take MRI, once you know the pattern, suppose the medial temple is affected, diffuse inflammation of the brain, or frontal is affected, depending upon which you can think. For example, the limbic encephalitis. If the MRI, if you see, more often the limbic system is affected, then HSV, HHV6, syphilis, LG1, and NMDA receptor encephalitis. If basal ganglia is affected, this is Japanese encephalitis, West Nile virus encephalitis, St. Louis virus encephalitis, and influenza encephalitis. If it is tropic for cerebellum, then varicella zoster, Epstein-Barr virus, mumps, listeria, and Whipple's disease. From encephalitis, again West Nile virus, Japanese encephalitis, enterovirus 71, rabies, and listeria, and tuberculosis. Encephalomyelitis, West Nile, JE, polio, rabies, VZV, and CME and ADEM. So then once you know this, then go for empirical treatment. Initiating empirical treatment is essential while awaiting investigation. Should not await for the investigation. Once you send the blood cultures or other tests, first start empirical treatment. Acyclovir is the first drug of choice in all sporadic viral encephalitis, because most common cause of encephalitis is herpes simplex encephalitis. So start with acyclovir, the suspected bacterial meningitis, high-grade fever, headache, vomiting, and then start with third generation cephalosporin, ceftriaxone at the 2 grams IV. Most people give 1 gram. So you have to give the meningitic doses of ceftriaxone with the addition of vancomycin. Empirical artemisinin based on the combination therapy should be initiated when cerebral malaria is suspected. Always you have to give 2 drugs. Untreated cerebral malaria has a mortality of 100%. This is a line from Bradley. If you misdiagnose of cerebral malaria, the mortality is 100%. When there is suspicion, patient from endemic area, fever, altered sensorium, other investigations normal, even QBS is negative, we have to start with anti-malarial drugs, because the untreated malaria has a mortality of 100%. So empirical treatment, rickettsial encephalitis, like scrub typhus, doxycycline, initial treatment of choice. Erythromycin can be used in case of doxycycline resistance or contraindications. Primary abusive meningoencephalitis or granulomatosis GAE, where you can use rifampicin, azithromycin, codramexol, and fluconazole. So there are various drugs and doses can get in the textbooks. Very important is acyclovir. Acyclovir dose is 10 mg per kg IV every 8th available for 14 to 21 days. Minimum 2 weeks, depending on the response, giving up to 3 weeks. Varicella zoster again, acyclovir. EB virus, you can give IVIG. CMV, ganciclovir. HH6, you can give ganciclovir. And HIV encephalitis, combination of hot, highly active retroviral therapy, and rabies encephalitis, post-acute prophylaxis with rabies. So supportive care. Maintenance of IV fluids, very important in most of the encephalitis. Treatment of rise intracranial pressure. Maintenance of euglycemia and control of seizures. So common viral encephalitis. Once you know this, then what are the common viral encephalitis? Herpes simplex viral encephalitis, most common cause of sporadic encephalitis. So etiology is herpes simplex type 1 and type 2. Type 2 in infants, type 1 adults. The bimodalized distribution, one peak occurs in children, one peak occurs in old people. No seasonal predilection. Annual incidence 2 to 4 per 10 lakhs population. No general predilection. All age groups are affected, both children and elderly. Most important, they present with altered sensorium, fever, headache, psychiatric features, personality change, altered behavior, vomitings, facial, focal weakness, and memory loss. So most common being fever, headache, psychiatric features, altered sensorium, and memory cognitive features. So you can see importantly affects the medial temporal and frontal, and you can get hemorrhagic involvement. When somebody comes with hemorrhagic necrosis in the medial temporal and frontal with fever, headache, altered sensorium, personality change, always suspect with periodic lateral epiphyseal discharges in the EEG. You can diagnose, and CSF usually normal. You can get lymphocytic phagocytosis. So the important is treatment. CSF PCR for HSV for diagnosis with clinical suspicion, imaging, MRI, and confirmation by CSF, PCR for HSV. Then treat with acyclovir. Already we have discussed the dose. So all acyclovir resistance, postcarnate, acyclovir, shortage, ganciclovir, cerebral edema, mannitol, all these things. Next is brief few points about Japanese encephalitis. First reported in 1871 in Japan, Tokyo. 1955, first in India, North Arcot district of Tamil Nadu, Vellore, and caused by flavivirus, transmitted 2x mosquito virus. So common in rural, low socioeconomic status, usually more common in this season, September, October, July, September, October, August, rainfall, floods, paddy, and cultivation. So South India, 80% of patients below 15 years. In North India, 50% below, they occur in children. 1% of those individuals, less than 1%, who develop clinical features after incubation period. About 2%, 20% symptomatic patient develop for fatal encephalitis. Incubation is 5 to 15 days. You have 3 phases of Japanese encephalitis: prodromal, stage of prodrome, stage of encephalitis, and stage of recovery. So initially they present with non-specific features, then stage of encephalitis, fever, headache, altered sensorium. Recovery usually occurs in the neurological, they have neurological deficits, various movement disorders. So diagnosis, CSF, IgM, ELISA, PCR, MRI. Treatment, no antiviral treatment for Japanese encephalitis, only supportive care, 50% mortality. So vaccination, cell culture based vaccines recommended for people living in or traveling to endemic areas. Then dengue. Increased incidence of more than 30 times in the past 30 years. Now it's 2025. So 1995 to 2025, the 30 times increase in dengue virus encephalitis. Most important infectious disease with the pandemic proportions. Annual number of cases are 400 million worldwide, and endemic in more than 100 countries. Caused by, this is the flaviviridae, the 4 known types, dengue 1, 2, 3, 4. Usually prior infection with dengue 1 is most important to get dengue hemorrhagic, dengue encephalitis, or dengue hemorrhagic shock syndrome. Incubation 3 to 4 days, all present fever, headache, myalgia, joint pains, rash, and breakbone fever. Neurological complication 10%, they can present with encephalitis, fever, headache, altered sensorium, seizures. They can present like meningitis like illness, strokes, ICH, Guillain-Barré syndrome, and myositis. You can diagnose CSF and serology. MRI gives a clue. Already we told the patterns. No antiviral treatment, only symptomatic treatment. Early recognition is very important, and ICU support whenever is required. Nipah virus not so common. We see these Nipah virus outbreaks periodically, especially in Kerala. First case of Nipah virus is in Malaysia due to paramyxovirus, endemic in Southeast Asian countries. Outbreaks in Malaysia, Singapore, Philippines, India, Bangladesh. See the hero, Lini Puthuseri, India's hero nurse who died of battling with a Nipah virus patient. His husband has Nipah virus. She was a nurse. She was serving husband, and she got Nipah virus, and she was no more. And you see outbreaks, the mortality is very high with Nipah virus. So contact with fruit bat, flying fox, contact with either food bat or intimate host like pigs or Nipah virus patient, either primary host, intimate host, or a Nipah virus patient. So this is very important. Incubation period is less than 2 weeks. Within 2 weeks, they can be fever, headache, respiratory symptoms, acute neurological features like focal weakness, GB syndrome-like presentation, brainstem dysfunction, seizures, and subacute like late onset encephalitis, and long-term like relapsing encephalitis. So there's a different diagnosis. Investigation RT-PCR and thrombocytopenia, leukopenia, very important. MRI, you get temporal lobe involvement and confluent hyperintense cortical lesions, very classic of Nipah virus. No antiviral treatment, anti-seizure medication, treatment secondary infection, mechanical ventilation. The mortality is 40 to 90%. 20% of survivors have neurological deficits. So we can prevent this Nipah virus because it occurs with contact tracing and quarantining of infected individuals. All patients and those who are serving those patients should wear PPE, personal protective equipment, and provision of education. Avoid consumption of fresh date palm sap. You go see interior to Seakorma or some places, you get a lot of this, not this date palm, but resembling date palm. So in especially endemic regions like Kerala, so aware of close contact with fruit bats. This fresh date palm sap is infected with this fruit bats. So endemic region, the use of barriers kits around the trees. So raising awareness among the clinicians. Introvirus sometimes cause encephalitis, which cause hand, foot, mouth disease, encephalitis, GB, acute onset myelitis, cerebralitis, Chandipura virus. Lot of cases of Chandipura virus described in Andhra Pradesh and India. So vesicular virus, rhabdovirus, RNA virus. A lot of outbreaks. You can see these outbreaks in Nagpur, Warangal, and Gujarat, and in AP. So again, high mortality. So diagnose RT-PCR and IFA technique. So lymphocytic urinary occurs usually patients who have immunodeficient states, high levels of lymphocytes during infection usually occurs in post-transplant individuals. They present like febrile encephalopathy leading to death. Scrub typhus, few words about scrub typhus. Nowadays, very common in the last 10 years. The one who present with acute onset of fever, altered sensorium, seizures with skin rash and systemic features like lymphadenopathy, thrombocytopenia, leukopenia, scrub typhus due to oriental Sushungamushi, increasingly recognized. Transmitted mite bite, you can see the small mite there. It causes lymphadenopathy, hepatomegaly, elevated liver enzymes, and thrombocytopenia. So compatible features of scrub typhus are Ishar, regional lymphadenopathy. Somebody has fever more than 8 days. Usually all viral infections get fever and subside within 4 to 5 days. Somebody has fever more than 8 days with increased CRP more than 22 milligrams per liter and ALP-AST more than 1 and deference in 48 to 20 hours, you have to suspect scrub typhus. But bone pain, bleeding time, and loose stools, which is unlikely to be a scrub typhus. So this is a diagnostic approach for various direct indirect methods. So scrub typhus infection criteria, that is STIC, positive in vitro cell culture, Tushungamushi, admission of IgM titers more than 1 in 12,800, fourfold rise in IgM titers, and positive sampling of user PCR techniques. You have to treat scrub typhus with doxycycline 100 mg every 12 hours for 7 days. Doxy 100 mg BD for 1 week. Or tetracycline 5 mg 6th hourly for 7 days. Alternative, you have azithromycin and rifampin. Azithromycin 5 mg on day 1 and 250 mg BD for 2 to 4 days. So pregnant women, azithromycin, alternative is minocycline, azithromycin, levofloxacin, or chloramphenicol. So you should know how to distinguish because these three looks alike. That is dengue, chikungunya, and scrub typhus. Dengue patients usually all will have fever and incubation period 3 to 1 week, 3 days to 1 week. So myalgia is very predominant. Predominant myalgia, thrombocytopenia, fever, with rash, dengue fever. Chikungunya fever, predominant joint pains, suspect chikungunya. Scrub typhus, the important is the Ishar, myalgias, and thrombocytopenia. That is scrub typhus with lymphadenopathy. So this is about infectious encephalitis, starting from viral, bacterial, fungal. The important viruses are JE virus, episymptomatic encephalitis virus, scrub typhus, and chikungunya and dengue. So one you should know about before we conclude. So autoimmune encephalitis, because they also can present with altered sensorium, seizures, and various other features. When to suspect autoimmune encephalitis? Change in baseline neurological function, subacute onset. Usually, viral encephalitis, usually they are acute onset. Subacute onset, fluctuating course. They get altered sensorium, seizures, psychiatric features. They're normal for some time. Again, they get another attack. Fluctuating course, personal history, family history of organ, non-organ specific autoimmune disorders, systemic markers of autoimmunity, and history of malignancies. One should suspect autoimmune encephalitis. Subacute onset, at least one of the following new focal findings, seizures, pleocytosis, MRI feels such of encephalitis, and reasonably you have to exclude other causes. So infectious and autoimmune encephalitis to distinguish flu-like symptoms, dizziness, malaise, headache, fever, they're present here. Here you get no fever, usually present confusion, altered sensorium, personality change, some facial-brachial dystonics is a specific facial-brachial dystonic like this. They get a face, break, hand. So facial brachial dystonic stages, movement disorders, like various movement disorders, unexplained movement disorder. So like chorea, somebody presents with chorea, young female with ovarian cancer, suspect autoimmune encephalitis, especially NMD receptor encephalitis. Young female coming with who is very, very good, looks very well, very lean, and that ovarian cachexia, what we call. So patient become very lean, subacute onset, altered sensorium with a movement disorder like. So abrupt, brief, rapid, jerky, flowing movements, one part to other part, the chorea. So any young woman or 30 years old woman underlying malignancy with chorea, with psychiatric features, personality change, abnormal behavior, suspect autoimmune encephalitis. One of the autoimmune encephalitis is NMDA receptor encephalitis. Based to autoimmune encephalitis, either NMDA or VGKC. NMDA usually occurs in young females underlying ovarian malignancies, whereas the VGKC occurs usually in old persons, males with underlying lung cancer. So a lot of encephalitis like anti-Hu, anti-Ma, GAD, NMDA, AMPA, GABA-A, GABA-B, leucine glioma inactivated rich encephalitis, Casper, DPPX, MOG, acoporin, and GQ1B. So define clinical radiological syndromes like limbic encephalitis, ADM, NMDA, all you can recognize the pattern in the presentation of this. So autoimmune encephalitis to subacute onset, bilateral brain abnormalities, CSF pleocytosis, and EEG you get epileptic slow wave activity involving the temporal lobes. So there are various NMDA receptor encephalitis. So there are two important encephalitis, NMDA and VGKC. I already discussed. NMDA occurs in young female with tumors, VGKC old male with lung cancer. So you can see here some of the orofacial dyskinesias in NMDA receptor encephalitis. The classical orofacial dyskinesia. Any young boy presenting with orofacial dyskinesia, insomnia, sleep disturbance, psychiatric disturbance, dementia, should suspect NMDA and facial-brachial dystonic stages. You can see that affecting the face and hand. So diagnostic criteria for ADEM. ADEM, one of the common cause of acute encephalitis syndrome. First, multifocal encephalopathy, there's altered sensorium, either drowsy, obtundation, stuporous, comatose with seizures in a child, suspect AD, Bickerstaff encephalitis, one of the variant of Guillain-Barré syndrome. So what is the treatment of autoimmune encephalitis? Give methylprednisolone 1 gram for 5 days, IVIG 400 mg per kg per day for 5 days, plasma exchange 5 to 7 exchanges administered every other day. Second line is either cyclophosphamide or we give rituximab 1000 milligrams IV followed by second dose in 2 weeks and once in 6 months. So prognostic and long-term sequelae, all depends upon the etiology, age, severity of initial presentation, and promptness of treatment. So viral encephalitis, complete recovery to severe neurological deficits and death. They may completely recover if you diagnose early, if you treat early, they completely recover. The mortality rate for HIV encephalitis is about 20% even with the treatment, and JE has 30%. Autoimmune encephalitis outcome is very good, generally most favorable, especially early and inappropriate treatment. However, some individuals can have residual neurological deficit and relapse can occur. So these are some of the changing scenarios faced in India, from JE to dengue to chikungunya, then Nipah virus, cryptyphus, then all JC, CME, HHV, and autoimmune encephalitis, toxin-mediated. So identification of these with autoimmune encephalitis. To conclude, acute encephalitis syndrome is a complex syndrome with diverse etiology and low diagnostic test and low yield of mycobacteria, low yield of bacterial viral isolation, making it more difficult to diagnose. Rapid assessment, appropriate investigations, and early empirical treatment are the essential for improving outcomes in acute encephalitis patients. Supportive care measures play a critical role. In case of viral encephalitis, early administration of antivirals like acyclovir is very crucial. For autoimmune encephalitis, immunotherapy, including IVIG 4 mg per kg for 5 days, plasmapheresis, and immunosuppressive drugs like rituximab, cyclophosphamide can effective when initiated promptly. So preventive measures like vaccination, vector control, hygiene, and multidisciplinary approach, and pediatricians, neurologists, general physicians, emergency doctors, infectious disease specialists, and critical care teams often necessary for comprehensive management of acute encephalitis syndrome patients. Thank you very much.
Thank you, Professor Gopi. It was a clear, extensive, and conceptual presentation. We are all enlightened by your talk. And now the forum is open for any questions. I think all are clear, so no more questions. So we will close the talk. Thank
Thank you
you.
very much, sir. Thank you very much for the
Thank you, sir, for the well-structured and thought-provoking session. And thanks to our chairpersons for leading the discussion.
లేదు సార్ బొకేస్తామని చెప్పాను సార్. ఇందులో కూడా ఎవరు రావట్లేదు.
మీరు మేనేజ్మెంట్కి దాంట్లో ప్రిన్సిపల్ మేడం కూడా ఇంక్లూడ్ చేసేసి అందరికి మేనేజ్మెంట్కి థ్యాంక్స్ చెప్తారు ఫస్ట్.
మేడం
మేడం
చెప్తారు సార్. ఎస్ సార్. బొకేలకు అమ్మాయి లేరురా. బొకేలకు అమ్మాయి లేరురా. ఇంటెన్స్ ఇద్దరిని రమ్మంటారా.
ఇప్పుడు ఎదిగిస్తారు ఏమేమి రెడీ చేయాలి చెప్పండి.
I request Dr. Madhusudan Babu sir and Dr. Usharani ma'am to felicitate Dr. Gopi sir. We are honored to invite our head of the Department of General Medicine, Dr. Sudhir sir, onto the stage.
I invite our Deputy Medical Superintendent, sir, Dr. Hemant, onto the dais.
A warm welcome to Dr. S. Sridhar Reddy sir. Please join us on the stage.
And we are delighted to welcome Dr. Madhusudan Babu, sir, Professor of Medicine, to kindly grace the dais.
It is an honor and privilege to invite Dr. Anuja Patil ma'am. Ma'am, please kindly join us on stage.
It gives me great pleasure to invite Dr. Anand Shastri, sir, our Professor of Medicine, to join us on the stage.
A warm welcome to our beloved Dr. Priya ma'am. Kindly join us on stage. We request a dignitary to formally commence today's session. Let us all invoke positivity and purpose with the traditional lighting of a warm welcome to Dr. Gautam sir, consultant neurosurgeon. Sir, kindly join us on stage. I request our dignitaries to kindly be seated. And to formally commence today's session, let us all invoke positivity and purpose with the traditional lighting of the lamp. I request all our dignitaries to kindly join us for the lamp lighting session.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दीपज्योति परब्रह्म दीपज्योति जनार्दन दीपो मे हरतो पापं दीपज्योति नमोऽस्तु ते दीपज्योति नमोऽस्तु ते।
I request Dr. Priya ma'am, our organizing secretary, to address the gathering.
Very good morning, respected dignitaries on the dais, our CEO sir, Dr. Sridhar Reddy sir, DMS sir, Dr. Hemant sir, HOD Department of General Medicine, Dr. Sudhir sir, Dr. Madhusudan Babu sir, Dr. Anand Shastri sir, and Gautam Dev Reddy sir, and our chief guest for today's session, Dr. Anuja Patil madam. I welcome you all. It is indeed a great honor and privilege for me, on behalf of the organizing committee, to extend a very warm and cordial welcome to each one of you to this academic gathering. We are privileged to have amidst us distinguished dignitaries, eminent neurologists, respected teachers, senior colleagues, young postgraduates, and enthusiastic participants from different parts of the state and country. Your presence here is a testimony to your commitment to learning, sharing, and advancing the cause of neurology and patient care. Neurology, as we all know, is one of the most fascinating yet challenging branches of medicine. It is a specialty that constantly demands critical thinking, clinical acumen, continuous update diseases. Conditions like stroke, epilepsy, dementia, Parkinson's disease, multiple sclerosis, and neuromuscular disorders are being redefined with newer diagnostic technologies, innovating therapeutic strategies, and ongoing research breakthroughs. The purpose of this Neuro Update CME is not just to provide an academic update, but also to create a platform where clinicians, researchers, and students can interact, exchange ideas, and translate evidence into practice. So, our goal is to ensure that the knowledge we gain here today directly benefits the patients we serve. So we are truly honored by the presence of our guest speakers and resource persons who have kindly accepted our invitation and traveled from near and far to share their expertise. So their lectures and interactive sessions will certainly enrich our understanding and stimulate our thinking. So before I conclude, I would like to remind all the participants that a CME is not just about listening, it is about active learning. I encourage you to participate wholeheartedly, ask questions, share your experiences, and take back valuable insights that can help improve patient outcome. So once again, I extend my warmest welcome to all of you. Let us together make Neuro Update 2025 an academically rewarding and memorable experience. Thank you.
Thank you, ma'am. Now I request Dr. Ramarao, sir, to join us on the stage. Now I invite Dr. S. Sridhar Reddy sir to share a few words with us.
Good morning, everyone. Respected Dr. Sudhir Garu, Head of the Department of General Medicine and Academic Director. Dr. Hemant Garu, Medical Director. The other dignitaries who are on the dais and the students and the doctors who are present. Actually, I want to, whenever I see such types of programs going on, I remember my post-graduation dates. And I envy the students at present who are here, that we never had such an opportunities to have so many continuous medical education programs. If we had once in 6 months, we would have feel so much enthusiastic and, as if, the festival is going to come and we used to count down the dates. But it's very unfortunate to see that there are people, learned people with the knowledge who come down here to completely, give the knowledge to you as if, taking out the banana and giving to you. You have to just gulp it. But even for that, I see most of the postgraduates and the people who require this subject are so lazy to come out from their comfort positions. Sometimes I feel sorry for that thing. Apart from envying you, I even feel sorry for that thing. And if you would have such type of teachers who are giving that type of encouragement for us, I think I would have been in a different position, not in the administrative position. I would have been in a very better clinician. Okay. So I request that the students should use these opportunities to learn and develop. And most of the time, whenever any CME goes on, I'm from the Department of Forensic Medicine. Practically, we don't have any much to learn every year, other than the continuous law and sections changed by the government. Otherwise, on the body, we have nothing much to learn. We always say that any new invention in forensic medicine, we say, yeah, it happened 100 years back. That is, they have invented a latex glove. And that's the only new invention in our department. But when we see about the clinical department, especially like general medicine, every day there is a new invention, new thing coming into the place, either in the diagnostic, either in treatment procedures, either in the changes in the disease patterns. So you require a lot of updates taking place every month. And these are the platforms for such type of things. So I request all the students, whenever we talk about now neuro updates, people think that, oh, neuro updates is only for general medicine. Okay, it's only general medicine coming to place. The reason behind that thing, it is we are treating the human body. Once we become specialists and super specialists, we are only seeing that part of the body. We are not looking into the human. So we are not treating any more human. We are only treating the part of the bodies. But still, we need to remember that any pain in any part of the body is for the entire body. So it has to be looked completely. So what I mean by that thing, this type of topics are not limited to general medicine. They are equally important for surgery, equally important for ENT, equally important for dermatology, respiratory, any department you take, they require this knowledge. And once you are out from your post-graduation, you will be concentrating only on your specialty and nobody is there to teach you these things. So I request all the postgraduate students who are present here from Department of General Medicine and from other departments present to enjoy this and take home the message. Thank you.
Thank you, sir, for your kind and thoughtful words. I now request Dr. Hemant sir to share your thoughts on the CME.
Respected dignitaries on the dais, my dear colleagues, delegates, and dear students. At the outset, on behalf of the management and the administration, I welcome you all to this Neuro Update 2025 at GEMS Srikakulam. I also take the opportunity to congratulate the Department of Medicine for their continuous and strenuous efforts to update the students and delegates continuously on various topics, enlightening them and then taking home the message that medicine is a subject which needs to be continuously evolved and developed over a period of time to offer better services and treatment to the needy patients. So coming back to the update today, I'm sure a number of topics will be covered. And during the course of the day, all these topics will be informative, educative, and very much needed for your day-to-day practice. I request the delegates and the students present here to make full use of this update and be more enlightened and use this information in your uh, enlightening your skills and knowledge. Thank you for giving me this opportunity. Thank you.
Thank you, sir, for sharing your thoughts on the CME. I now invite Dr. Madhusudan Babu, sir, to speak a few words and grace this occasion.
Good morning to you all. At the outset, I thank the organizer, Dr. Priya, mainly. She is mainly the backbone of this CME conduction. And respected dignitaries on the dais and dear delegates, good morning to you all. Any CME, I'm going to be very brief. Any CME about learning. So here there are people who are talking about the topics with lot of experience in dealing with these cases, and you are fresh with subject, so the knowledge gap of the recent developments will be bridged here in the CME. So that will change the way you look at the cases, the clinical cases, how you look at them, how you are going to approach the patients. All these things will be changed if you attend the CMEs properly. So I request all of you to pay attention, hear all the topics, and take home the knowledge and prosper in your lives. Thank you.
Thank you, sir. I now request Dr. Ramarao, sir, to share a few words with us.
I want to congratulate the Department of Medicine, particularly Dr. Sudhir sir and others, who has organized this program. So, as per the definition of health, health is defined as physical, mental, and environmental well-being. So, most of us are forgetting this mental health. Mental health means not only a psychiatric problem. Mental health is very, very important nowadays. The problems are becoming more and more. So, this update will help you to regenerate your knowledge in the undergraduate level knowledge. So, we are very fortunate that so many CMEs are conducted in the Department of Medicine. So, I wish all the other departments also follow in suit, and I wish this CME will be a great success and beneficial to all of you. Thank you.
Now I warmly welcome Dr. Anuja Patil ma'am to share her thoughts on this occasion.
The only motto I came here was like I'll get to teach. So talking and all will go on. I think we should rather start with the program. So, and just for a disclaimer, like we came here to encourage participation. So it's not going to be a didactic lecture. Lectures, we were doing it that online since long. So if we are coming here, I'll expect full participation from you people. If you don't ask questions, I'll start asking some. Okay? Sure.
Thank you, ma'am. Thank you, sirs and ma'ams, for sharing your thoughts on the CME. May I request all the dignitaries on the stage to kindly take their seats in the audience. And with that, let's start a scientific session. Thank you.
With great pleasure, now I invite Dr. Anuja Patil ma'am to deliver her talk, and also I invite Dr. Sudhir sir and Priya madam as chairpersons.
Display చేయండి. So, good morning. It gives me great pleasure to introduce today's esteemed speaker, Dr. Anuja Raghunath Patil. Dr. Patil is a distinguished neurologist with an impressive academic journey and clinical expertise. She completed her MBBS from the Rajashri Chhatrapati Shahu Maharaj Government Medical College, Kolhapur. She then pursued her MD in General Medicine from the prestigious SET GS Medical College, Mumbai, followed by her DM in Neurology from the renowned Postgraduate Institute of Medical Education and Research, PJ, Chandigarh. Uh, her skills, she has obtained uh, a FEBN qualification and completed a postdoctoral fellowship in epilepsy, marking her as a highly specialized expert in this field. Currently, Dr. Anuja Patil serves as a consultant neurologist at KIMS Hospital, Sikandrabad, where she is actively involved in patient care, academic teaching, and research. Her commitment to excellence in clinical neurology. We are indeed privileged to have her with us today. Please join me in warmly welcoming Dr. Anuja Patil, who will be sharing her insights and expertise with us. So I
Thanks a
welcome
lot.
Dr. Anuja Patil ma'am to deliver her talk.
Thanks a lot, madam, sir. First of all, outright, I'd like to thank for this opportunity, especially to interact as well. It was a long dream to become a teacher for me, but my parents brainwashed and made me a doctor. So at least this purpose serves me both purposes. So, and the program is very well organized. I went through the brochure also, topics, everything has been very well selected. To have something of this sort gathering at this early stage in medicine also, it's going to be a great honor, benefit for the students as well. Hopefully we make it as well. So I'll come to my topic now. Coming to epilepsy, like we all know, the global burden all over India as well is very huge. We have nearly in our country almost like 10 million people suffering from epilepsy, and hardly some 25% or one fourth actually receive some proper medical care. That means, on an average, in India, for practicing physicians, if one person with epilepsy is being seen and treated, there are 7 to 8 after him which are missing care, which are missing proper diagnosis and treatment. And therefore, the onus lies upon people, young people like you, to come forward, learn, and you need not be a neurologist for this. A great physician is someone who identifies at the right time, tries to treat. Most of the cases will be treated. Almost two-thirds to three-fourths of epilepsy cases will be managed at the very first junction only, first level itself. Very few advanced ones, refractory ones, will move on to the next referral centers. Before we start, a basic understanding about the terminologies. So what do we mean by a seizure, epilepsy, convulsion? Too many different terms and confusing meanings about it. Seizure is the event. It can be a single, provoked, unprovoked. It can be a motor, a sensory phenomena, sometimes focal, sometimes generalized. Single event when it is caused by the symptomatic cases like hyperglycemia or so, or it may be a repeated events or so. That one episode is called as a seizure. The books do still include the terms called as convulsions, the motor manifestations, tonic-clonic movements, myoclonic movements, and all. The motor manifestations is what is termed as convulsion. Term is now by far outdated. Seizure is the event, and the recurring seizures, when accompanied by other clinical features, imaging features, EEG features, together classify them as epilepsy syndrome. Now, the ILE has defined as epilepsy is a condition wherein an individual having two seizures 24 hours apart, or even at the very first seizure, if he shows characteristics, there are abnormalities on the EEG, there are abnormalities on his imaging, and there is a high suspicion or likelihood that the person is likely to get seizures eventually in the future as well. These people only will be classified as epilepsy. The classification, okay, seizures are focal, generalized, sometimes if not corroborated by any eyewitnesses, it could be an uncertain onset. Similar repeated focal seizures or repeated generalized seizures will be classified as a focal or generalized or focal to secondary generalized epilepsy. And when such epilepsies are associated with age-related epilepsy or EEG-related clinical features, characteristic stigmata of clinical features, they will be classified into epilepsy syndromes like mesial temporal lobe syndrome or juvenile myoclonic epilepsy syndrome, Lennox-Gastaut syndrome. These are syndromes. They are set of seizures, clinical features all put together that classify or define a particular syndrome. Now, over the time, people have new classifications are updated. These are not just meant to increase our workload. By the time you are just learning and updating yourself for one classification, the next classification is already into the books. So these are not just to increase the time or duration, like for study material for the students. Newer understandings, what started very initially as only one was grand mal, one was petit mal. What started from just these two types, today on an average we are having such a huge classification, types, subtypes, reclassification of epilepsy. Good understanding of epilepsy, the level of epilepsy, network hypothesis, everything helps us achieve good targets and improve the treatment paradigms at least. A basic part of education is not just learn and once and for all. It's learning, unlearning, and then relearning as well. So this is the current one, the 2025 basic updated classification, at least. I don't know with the 22nd edition. That's the latest, I hope, Harrison's edition. If it has still had hands on to this classification, we have moved from what was initially classified as focal, aware, unaware, focal onset seizures to back to classification as focal and generalized consciousness preserved or impaired. So this will be further classified and described as semiology is the study of seizure patterns. We divide this as a pre-clinical, pre-ictal phase, an ictal phase, and an post-ictal phase. Pre-ictal is more often premonition, what the person feels, what the patient can still recollect, and tell us about. These are most often sensory phenomena, sometimes psychic, deja vu kind of phenomena, sometimes only paresthesias, sometimes visual or auditory phenomena. These are sometimes things which are recognized or recollected by the patient before the impairment in consciousness or dyscognitive state happens. During the ictal phase, it could be a focal, generalized, focal onset, myoclonic, tonic, clonic, different terms to describe just the motor manifestation of the seizures. We will rather go into this when we come to the videos. Post-ictal phase, again, if a person is amnesic, most often so, post-ictally remaining amnesic for the event. Post-ictally, sometimes after a prolonged motor tonic-clonic seizure, sometimes they develop a focal paresis called as Todd's paresis. Some of them with posterior cortical onset or so will have post-ictal persistent blindness, sometimes auditory deafness as well. So these are the terms. Whenever you will come across any epilepsy or a seizure patient in the OPD and you are describing it to your next day rounds or your seniors at least, you will be describing them as what the patient felt prior to he lost his sensorium, what actually happened, whatever the scenario, cases, witnesses or anybody could have described it as, and post-ictally what the generalized status of the person was. This is how we will describe a seizure episode. Now, how many of you are final years? Just raise your hands. We'll start with you. Just description, nothing at all, okay? Just see the video, plain English, nothing more. I just want you to describe what you can see here. First, just let the video run. Just have a look. Observe every point. Coming to each. Okay. So he was initially lying comfortably in the bed. Do we have a mic or anything? Or shout out. Just tell me. Do you think the patient is conscious or not? Throughout the episode. He's conscious? Yes, no? Okay. By the time it started, he just he was lying, looking at the TV, then got up. What was the posturing? What was happening for the hands?
Tonic.
Exactly. Good. Which side is tonic?
Hot.
The right hand went into a tonic posture. This is called as dystonia, a persistent, stiff kind of a odd posture kind. So one hand went into a tonic kind of a posture that was called as a dystonia. The other hand, he just keeps on flickering, doing some pinching kind of movements or so. These are called as automatisms. So whenever any ictal, a discharge will start, it will go to the basal ganglia, ipsilateral basal ganglia, contralateral hand will develop a dystonia. By the time it progresses into orbitobasal structure of the brain at least, this is called as a release phenomena. A person will either start picking at his clothes, start wiping his face, sometimes lip smacking, which is going around at least. Could we appreciate that? So lip smacking movement, some purposeless, like repetitive postures, something going on at least. This is what orbitobasal lobes. We are not yet thankful about how far orbitobasal lobe is keeping you sane. Half of the class will be wanting to run away and sleep, but your orbitobasal lobe is keeping you here at least, listening to the classes. So this is how the seizure was. This is a typical focal onset. He is conscious, but he's senseless. By the time people are coming around, wiping his face and all, he is immaterial. He is not even bothered about anybody. So this is a focal onset impaired awareness. A typical dystonia is a localizing feature at least. This suggests that the onset is on the contralateral side at least. Okay. So this throughout the episode, if the person does not lose his consciousness, there are no any tonic-clonic movements or so. This was a focal impaired aware seizure. There was dystonia on the right hand side, so most likely coming from the opposite side of the brain at least. Thank you. Your name?
Prashanti.
Thank you. Give the mic to your next person. Don't return it. So this fellow had, if you can, I see if you can appreciate the EEG. EEG, red is right side, blue is left side. So left side is feasible. We can see some spikes. So these are the spikes. This is the routine background rhythm. There are spikes onto the left side. And in the MRI, if you can see, this is a normal right temporal lobe. This is the left temporal lobe, which was having mesial temporal sclerosis. There is volume loss, there is hyperintensity, dark sclerosed kind. So this is a typical mesial temporal lobe sclerosis kind. patient. The most common presentation would be this kind of seizures at least, need not always. Now you will be describing this lane. So most of the intractable seizures in routine OPD will be MPS. You can do your commentary side by side. It's going to be a little long lasting. So, like, what was happening to her? Which hand is immobile and which hand is moving?
Impaired awareness. Impaired awareness and movement initially started in the left upper limb, followed by right.
Yeah.
Impaired awareness, ma'am. Initially, the automatism started in the left upper limb, followed by right upper limb. Tonic movements simultaneously.
So, if at all we are classifying, how we can classify this? Had initially impaired access. She was conscious at the beginning at least. So, some certain movements started. Thereafter, the right hand went into a systolic position. Left hand. Right hand continues to still do the automatic movements. Thereafter, there is tonic movements of the face and tonic movement. This was focal to begin with.
Focal with impaired awareness. Generalized, secondary generalized.
Perfect. This was also a typical another case of mesial temporal lobe sclerosis only. So one side dystonia, one side persistent automatisms is the classical hallmark of how a seizure, your and mesial temporal lobe seizure goes at least. So this is another. Sit down. Sit down. Thank you. Your name?
Vaishnavi, ma'am.
Vaishnavi. Thank you, Vaishnavi. So this is another most common focal epilepsy in India. It originates in hippocampus, amygdala, parahippocampal gyrus area. Most of the reasons, at least, kids will have febrile seizures in the childhood. Very few of them go on to develop febrile mesial temporal lobe sclerosis and refractory epilepsy in the future. Very well controlled otherwise with medications. Few of them, nearly 25 to 30% of them will become refractory, not getting controlled with medications. Ultimately, the gold line of treatment would be surgical options for them. Now, okay. This video was captured in night. So she was in our lab. She's sleeping right now, sleeping soundly. EEG is showing some sleep markers also. Most often, these cases will be treated by psychiatrists. It takes time for them to even come back and being considered. Imagine something like this happening at night at least. How many of us will have a at least suspicion that this is a neurological or neurological entity? Can you just describe what you saw? She was just like lying sleeping.
She was
Then
like-
there is no premonition or anything. She gets up, gets time to call her, so nothing happens here. MTS gives you time. MTS, at least people develop a behavioral arrest. They at least have that much kind of a aura phase in between. Here, just rapidly, suddenly she gets up, thrashing in the bed. There is no particular tonic, clonic, any movements also. Just thrashing in the bed, rotating. So gyratory movements. This is something what we call initially getting stuck, silent and staring was hypomotor. This is opposite of a hypermotor or hyperkinetic. So this is a typical frontal lobe seizures at least. Seizures need not follow a typical pattern or so. Sometimes frontal lobe seizures can present with, it is not on. Sometimes it may or may not present with just some focal onset seizures kind. More often or not, these people will present with, this is called as sleep related hypermotor epilepsy at least. Okay. Name? Say it in the mic.
Akhil ma'am.
Thank you, Akhil. So, although the earlier seizure movements were all throughout the body. So, focal onset or generalized onset is not based onto the person's body. It is onto the onset, ictal onset in the brain. Generalized seizures, the onset will be somewhere subcortical and entire diffuse network gets activated all at once at least. Different types, absences, myoclonic, tonic-clonic or atonic seizures are all clubbed together under the category of generalized onset seizures. Yourself. Now, this is a young 12-year-old girl. She was hyperventilating. Now she's talking.
Absent seizures.
Perfect. Perfect. Thank you. Your name?
Joshna.
You did my job. So no tonic-clonic, nothing. Just go blank for a while or so, staring around. Sometimes even absences can have oral elementary absence, like automatisms are quite very few. But brief episodes, and these kind of episodes will be recurring throughout the day, almost 10, 15, sometimes even hundreds in a day at least. That EEG what we are seeing right now, this is the hallmark of absence epilepsies. What we call as 3 hertz.
3 spikes.
3 hertz spike and wave. So spike and wave, dart and dome, different kind of descriptions. Usually starts here early in the childhood absences or so, multiple 10, 15, hundreds of seizures in a day. Each will have that kind of runs of discharges almost. It can go on for almost 8, 10, 15, 20 seconds as well, precipitated by hyperventilation also. Few of them, they go on to evolve as juvenile absence epilepsies also, developing some secondary generalized seizures as well. Most of them are very well controlled with medications. Okay, name?
Joshna.
Jyosta. Thank you.
Thank you.
You will be describing just the video, not by the time you stand, it will be over also. Sorry. Child is lying in the bed and only this thing happens. So this is kind of an abrupt jerk. Jerks to either the facial as well as axial musculatures just had a rapid jerk. This is a typical, what kind of jerk? Myoclonic jerks. So sit down. Thank you. Your name? Shrikant. And the side what we are seeing EEG, different than the earlier EEG. Earlier EEG had runs of discharges at least. Here what we are seeing are discharges, scattered discharges, high amplitude, spike, polyspike kind of discharges, scattered discharges, relatively normal background, normal examination, often normal imaging as well. So juvenile myoclonic epilepsy starts somewhere in the early adolescence or so, normal cognition, normal imaging features, everything, and discharges will be high amplitude, scattered discharges at least, fragmented. Very rarely such cases at least. Now this lady, as we saw in absences at least, it gets precipitated with most often with hyperventilation. Photic precipitates JME also. Now this girl was a known case of JME while tapering or not, when EEG was being done, and photic stimulation itself, during the photic stimulation she started getting repeated myoclonic jerks also. So most of these kids, they go to the fairs, they see those twinkling lights, and sometimes, and that can also precipitate such kind of seizures for them. So by the time EEG was getting recorded and the first photic protocol only was started, she already developed a secondary generalized seizure. So generalized epilepsy, generalized seizures are different. So myoclonic JME can just come to you with brief myoclonic jerks only. Whether or not to treat will decide whether or not the person is at risk of developing even secondary generalized seizures also. So patients who are already having generalized seizures, they come to you itself the first generalized seizures. Then you go into the retrospect, ask them repeatedly, have you at least had any time morning jerks, clumsiness, dropping objects from the hands or so. That history will corroborate that the diagnosis is most likely JME. And once they come to you with a generalized seizure at least, it merits treatment. Despite heavy load of epileptiform discharges onto the EEG, if the person has not had any generalization throughout the onset of his symptoms, throughout the onset of myoclonus, very less likely for them to develop into secondary generalized seizures at least. So, and then there is a terminology called as GTCS only. So idiopathic generalized epilepsies, few class of epileptic, these generalized epilepsies are GTCS only. They won't have these myoclonus, absences, or any history in the childhood. There will be only GTCS in the history. Now, One more. This is a small child. That's it. What we saw initially as a small jerk. For this child, it was a bit more huge. There was almost, the head almost dropped down. This was initially what was called as the child drops, and there is a flexion of the hands as well. Salam fits as well. Good. Name? Okay. So salam fits, drop attacks, epileptic spasms. Sit down. So these epileptic spasms, most common etiology in India, at least, again, hypoglycemic injury or hypoxic ischemic injury in the childhood. The EEG is characterized by high amplitude burst of discharges, at least, followed by a slow wave, and then the normal background resumes again. More often, like if at all imaging everything is normal, genetic causes or cryptogenic causes, very high, like starts as epileptic spasms, West syndrome in the early childhood. Thereafter starts developing even tonic seizures. Thereafter starts developing even generalized tonic-clonic seizures, multitude of seizures. That syndrome is classified as Lennox-Gastaut. So West in the early childhood with typical drop attacks. Thereafter developing further neurocognitive decline, and other seizure semiologies will be classified as Lennox-Gastaut also. So etiology across the age, as childhood, then adult, juvenile, adolescents, then your young adults and late adults, elderlies. Different kinds of etiologies can contribute to onset of seizures or epilepsy. What we saw till now was more often a idiopathic kind of, or mesial temporal lobe sclerosis, or so kind of structural epilepsies. Now, treatable classes also. This is a elderly gentleman. He had presented with just repeated twitchings of face. It had been going on for almost hours since the day. MRI I have shown into the opposite side. MRI had shown typical hyperintensity of the like parietal occipital regions, bilateral, right more than left. His sugars were almost 453. So one of the another treatable causes of seizures. Seizures need not always be an epilepsy. Seizures, provoked seizures causes will be something like hyperglycemia, hypoxia, sometimes your metabolic causes like hepatic insufficiency, renal insufficiency. This is another girl who had presented, young girl, almost 18-year-old. She had presented with 3 episodes, one during awake state, 2 in her sleep also. Mother had just seen her unconscious in the bed, tonic posturing, some frothing from the mouth, incontinence of urine. So I have nocturnal events, loss of consciousness, incontinence, there is postictal confusion, tonic posturing. Everything is a stigmata of a seizure. Her CT brain was normal. EEG was grossly normal, but what was not normal was her ECG trace during the graph. And her ECG trace was showing intermittent missed bits. By the time she had completed her EEG, almost had a almost near cardiac arrest, had to be revived into the OPD itself. She was later diagnosed with prolonged QT syndrome. Prolonged QT syndrome causing prolonged hypoperfusion and manifesting as hypoxemic seizures. So whenever encountered with a new onset seizures at this age, anything that presents in juvenile or adult ones need not always be a typical JME or so. Do look for general examination, pulse, BP, postural drop of blood pressure, everything important. This is another gentleman who had presented with this episodic confusion kind. He would have some groaning movements, right hand will develop some posturing, with left hand he would go on grabbing objects, what we typically saw initially as a focal onset impaired awareness kind of a seizure. However, here creatinine was almost 10.4 and MRI had shown bilateral basal ganglia hyperintensities. Okay. So this was a renal insufficiency case which had presented with repeated focal seizures. Started on dialysis. By the time the patient, after a couple of dialysis at least, both the movement disorders, jerks, cognition, everything had improved. So treatable causes of seizures also, these hyperglycemia or metabolic causes, these are not classified as epilepsy. These are seizures. These are provoked or symptomatic seizures. You correct the cause, if the etiology gets corrected, likelihood of getting similar episodes in the future comes down. So they won't be classified, although at the acute onset at least, you may be treating them with medications. Now this elderly lady, she had presented with repeated thrashing kind of movements, bilateral hands.
Excuse me. Hello.
These movements will go on and on and on for almost 15-20 minutes together. during this, prior to and after the onset at least, entire EEG background, everything used to be normal. No age is immune for psychogenic problems. So even in elderly, although labeled as non-epileptic psychogenic attacks at least, need not always be, like, it's not functional. That terminology is still under debate. They don't do it wantedly. There are past history of childhood trauma, maybe some difficult or faulty coping mechanisms, and this leads into perpetuation of some faulty habits. This is the way they will be coping their stress. So always needs a calm and patient attitude here. When confronted with a patient, at least, first thing starts with a detailed history. If you ask me what is the most diagnostic test to diagnose an epilepsy, the first and foremost answer lies in history. The way the seizure is being noticed, described, the way patient can describe you pre and post ictery, whatever happened. These are far more diagnostics than any other tests all put together. Evaluation, examination, always general examination for vitals, pulse, oxygen levels, sugar levels, whenever any such patient comes into the emergency as well. So when confronted with a seizure patient, at least, first and foremost will be to classify whether or not that was a seizure or kind of a movement disorder, non-epileptic kind of episodes or so. You rule out mimics first, classify that it is a seizure. If it is a seizure, whether or not there are chances of it to develop any further recurring episodes in the future or so. Then we classify them as epilepsy and then pick up it accordingly. Now, once you have confirmed that the person has a seizure, next role comes evaluating them. EEG, similar to our electrocardiogram, also multiple, like montage is a like array, the way electrodes are being placed for recording the potentials. The layer 4 Beth cells neurons, they will be generating all these excitatory and inhibitory potentials, which will be summated together and recorded via the electrodes. So the routine EEG background waves described as delta, theta, alpha, theoretically yes, but if you can make out in this diagram, at least the upper topmost, this is the alpha routine rhythm, fast alpha. Then by the time a person is a bit drowsy, maybe some like any metabolic causes or so, or as per the age, theta range a little slower compared to the alpha range. Compared to this, even further slow down delta. Very extremes of age, 80 plus to elderlies, or even very low, below 3 years age or so, age appropriate, even delta range will be normal. Or certain times when person is on sedatives or hypnotic medications, benzodiazepines, even they can have such a delayed or very slow kind of delta range background also. When confronted with any epileptiform or abnormal discharges across the recordings on the right and left, if at all it is coming only once, unilateral or focal region or a electrode chain, at least it is termed as focal. Different and asymmetrically coming up, it will be termed as multifocal. All throughout, right, left, and entire anterior to posterior electrodes showing the discharge all at once will be termed as diffuse or generalized. So this is an abnormal EEG, focal discharges. We can see it along the left temporal chain. These are certain other types of epileptiform discharges. We can see here focal discharge here, only one per page or abrupt spike is seen here. This will be regional, entire this left side, entire anterior region of the left hemisphere is spiking, sometimes lateralized kind. So both the sides are spiking, but not synchronously, at least both are differently. And then bilateral, starts nearly symmetrically in both the chains, both the sides. How far after EEG, if we are getting any persistent focal discharges or slowing in the background, at least these patients definitely should undergo imaging. If not, and generalized, what we saw initially also, absence epilepsy kind of a graph is seen, or JME kind of graph is seen. These are epileptic like EEG markers of idiopathic generalized epilepsies. Here I expect, or more often the cases are going to have a normal imaging. We can wait, maybe if at all the person is not getting covered, like better control with the routine line of management, then subject them for imaging also. So for any given seizure patients, imaging is not a must unless in young onset, the most common focal epilepsy commonly seen in our scenario will be a neurocysticercosis. So first time a person comes to you with a focal secondary generalized seizure, at least definitely at least a CT if the vitals are stable. If at all hemodynamically unstable, stabilize them, treat, and thereafter subject for imaging. So most of the cases which we see in our emergencies, half of them will be most likely mimics or metabolic causes. Thereafter we possibly diagnose people who did not have any provocative, any symptomatic causes or so, classify them as likely unprovoked seizures. Unprovoked seizures with some abnormalities onto the imaging or examination are likely to have epilepsy syndromes. And out of these epilepsy syndromes, at least very few are going to become intractable and merit further evaluation at least. So, as I had told initially, also nearly 2/3 of the cases get managed with medications alone. Appropriate diagnosis and appropriate choice of medicine, most of them will be treated at the very first juncture. Hardly a 25% or 30% of cases will move on to need for further evaluation, detailed evaluation, and need for any surgical treatments or so. Out of medications, easier initially, now at hand, at least we have nearly 25 anti-seizure medications with us. To remember which anti-seizure medication, how it works, I think your diagrams and books do describe it very well. I would just like to highlight certain points. Sodium channel blockers are the best line of medication for focal epilepsies. Generalized like or multi-phase acting drugs like valproate or levetiracetam, SV2 inhibitors at least. These are like broad spectrum anti-seizure medications. You use them, at least we are not at choice of at least worsening any other seizure patterns. So carbamazepine, iptoin, or lamotrigine, lacosamide are the drugs of choice for focal epilepsies. Valproate, levetiracetam, brivaracetam, drugs of choice for generalized seizures at least. What not to choose also? Sodium channel blockers are very known to precipitate or worsen absences or juvenile myoclonic epilepsies. So any person who comes with history of myoclonus or so or persistent staring, definitely avoid these drugs at least. During pregnancy, the only two drugs which are currently validated, FDA approved for treatment of seizures during pregnancy, lamotrigine and seen into a little late state of pregnancy, it is better to continue the medicines which she's already on, because rather than creating harm because of the medications, getting seizures during the later stage of pregnancy is far more deleterious. So seen into an early stage within the first trimester or so gives us a time to put her into a better combination of medications. Seen into a little later stage or so, better to continue the medications because part of this fetogenesis or organogenesis has already been crossed. More often 46%, almost 46 to 50% of cases will be getting controlled with a single anti-seizure medications. I put her on anti-seizure medication, seizures are not getting covered. Patient is coming back again and again with intractable seizures. Adding a second anti-seizure medication is only giving me 12% of a benefit. Thereafter, third or any further anti-seizure medication is only giving you a 4% of benefit. So just because seizures are intractable doesn't mean that we will go on adding anti-seizure medications after them. Certain combinations do work better, as lamotrigine and valproate put together has shown good efficacy. Valproate and ethosuximide has shown better efficacy for absences. Lacosamide and levetiracetam works better in combination at least. Synergistic combinations based on their mode of actions and trying to avoid similar lines of adverse effects at least will be fruitful for us. Again, management of status, I think so we'll need another class for this. So the last 1/3 of cases at least which are not getting controlled despite use of proper or streamlined choice of anti-seizure medications will be moved on for evaluation for epilepsy surgeries. At least two types of surgeries, curative and palliative. Curative, wherever I have a focus, non-seizure focus, epileptogenic focus, and goes for resection, that is a curative kind of a surgery. Wherever there are multifocal epilepsies, bilateral foci, at least for such a cases, disconnection syndromes like callosotomy or VNS will be a palliative kind of a surgery. ILE recommends that persistent seizures, at least lasting for 2 years or so, with well-tried anti-seizure medications, two well appropriately chosen anti-seizure medications tried for a at least appropriate amount of time and has proved unsuccessful in controlling seizure durations, are like such cases should be considered for evaluation for epilepsy surgery also. Timely referral can at least save their further cognitive deterioration. So, inside, like we will have one like mesial temporal lobe sclerosis or so. That sclerosis is the epileptogenic zone. Ictal discharges start from this zone, go on to move on to other eloquent cortices and manifest. So during seizure, like if that earlier fellow has to come for a seizure surgery, we won't be chopping off half of his brain. It is the only epileptogenic zone, focus, onset, which will be recommended for surgery. So of all drug-resistant epilepsies, hardly 1/3 will be a potential candidate for surgery. And out of all, nearly 60 to 70% go for a long-term seizure remission also. So patients who are medically refractory should be referred for a comprehensive epilepsy evaluation. So remember, diagnosis of epilepsy is mostly clinical. EEG and imaging are only corroborative. Classification of the seizure types and epilepsy syndromes helps in better understanding the course of syndrome, identifying the right treatment modalities. And goal of treatment is not only seizure control, it's improving the quality of life of the person as well as their family. Okay. Thank you.
Seeing is believing. And Dr. Anuja Patel, she made our students see the actual cases and believe how they will behave. And this is a great experience, very wonderful lecture, and very exemplified, very well handled. Thank you so much, ma'am, for enlightening our students with your lively videos and illustrative lecture. Thank you for coming all the way from Hyderabad to give your knowledge, share your knowledge with us. Thank you so much. Give her a big hand. Yes.
Thank you, sir. Thank you. Thanks a lot.
Any questions from your audience? Any questions from your audience?
Hello. Hello.
Third question is that VNS stimulation versus sclerotomy in DR.
So coming to the first one, febrile seizures at least. Typical febrile seizures and very like wide apart, once in a while kind. One seizure now, some 2-3 years back, another seizure or so. Very rare apart seizures, very less likely for these kids to develop MTS in the future. So we don't go on treating like long-term medications for them. They will only be on prophylactic medications. Any child who comes to you with prolonged febrile seizures or repeated febrile convulsions which are recurring again and again. So atypical febrile seizures, what we call. These are very high likelihood to develop febrile seizures or MTS in the future at least. They have did even cytogenetics of whatever these specimens after like resection what we send them. So there are certain NMDA and this AMPM molecules which are overexpressed in these kids. Febrile seizure is almost kind of a pre-ictal phase starting in that young age at least. So repeated febrile seizures, not all kids are prone for developing febrile seizures for every fever that they get. So repeated seizures or prolonged febrile seizures at least merits treatment, even long-term medications. Those initial 2 years of treatment may lessen the likelihood. It may not be again completely fruitful also. There are kids who have been very well treated, controlled during the early childhood. They were weaned off the medications and then somewhere late into the second or third decade, they start developing seizures again. But using like prophylactic 2 to 3 years of medications for repeated seizures or prolonged febrile convulsions in the early age definitely is protective at least. About the NMDA. So MTS developing into NMDA. MTS patients reasonably very well controlled. 3 to 4 generalized seizures in a year. Once in a while, focal seizures at least. This is how a typical MTS will behave. If they are getting repeated seizures, there is a concurrent memory decline associated with it. Or patients, especially those who come with, they're having signs and symptoms of one, and then you go and do the MRI, and we find that there is a bilateral MTS also. So these are the ones which are harboring subtle like some antibodies inside also. So there are now antibodies, anti-GAD antibodies, which have been not just NMDA. Anti-GAD antibodies have been isolated in patients with chronic drug refractory mesial temporal lobe sclerosis patients as well. So how far antibodies are just a marker or paving way into the pathogenesis of the seizures merits. But any like subtle cognitive decline, rapid cognitive decline setting in, or repeated seizure setting in, these are little behaving different from the typical MTS patients at least. And about familial things, till now at least, literature has only 2 case reports. We had another one, NMDA running into families. There are kids as of now at least, whatever, these 3 cases till date at least, all are in siblings. It is not like a mother had and a child is also having also. Till date, at least I couldn't find in the literature. But siblings do have propensity to develop NMDA. There are certain HLA biomarkers also. The one that we had in our case, like our setup at least, both the girls, one was elderly 21 year old, the other girl was 19-year-old, and she had, both of them had developed NMDA encephalitis just 6 months apart. The elder one had succumbed to her illness, second one reasonably very well treated because treatment was initiated very soon. But HLA if we go for analysis of these cases, at least there are predispositions likely, maybe environmental as well as this genetic predisposition, which can cause familial tendency of NMD at least. 3. VNS versus, yeah. So these are palliative. So callosotomy, especially for cases, callosotomy won't stop all seizures. Callosotomy will only stop the bilateral spread of seizures. So kids which are getting those repeated epileptic spasms, drop attacks, tonic seizures. Tonic is because of the bilateral rapid spread. That will be aborted by callosotomy. But focal seizures, any like multifocal seizures or so, those hypomotor seizures, those won't be controlled by callosotomy. Compared to VNS, callosotomy is chosen for cases, subset which has repeated drop attacks, epileptic spasms, tonic seizures only, GTCS also. VNS has not as much as efficacy as callosotomy, 60 to 70% patients, that too because they are still continued onto anti-seizure medications at least. So palliative, cumulative with medication optimization and VNS put together, the seizure freedom is coming down to almost 60% or so. Yeah.
Whether that patient can have some, we are having some genetic generalized epilepsy syndrome. So whether that prolonged QT syndrome is due to the same as like Dravet syndrome, which has SCN mutation. Can it be like that, or this can be isolated thing we should identify?
She was advised genetic, but they didn't go for it. This case, seizures had started just immediately, and we could identify the ECG abnormality also. She was just put on to 300 BD of mexiletine. Until now, 5 years down the line, she is seizure free. At the same time, right now, I have another child who is having recurrent runs of PSVTs. His and seizures are going on since almost 15 years. Child is now 22-year-old, and since the age of almost 12 years or even younger, seizures had been going on. So seizures are going on way too in advance. Something like QT or so predisposing to seizures precipitates very soon. Seizures won't be lasting for some years together in the background, that running in a separate mode, this running in a separate mode. Definitely not. Something of that gravity, at least child presents with some syncopal attacks or sometimes even cardiac arrest kind of manifestations, and